Let's start the new system, that's cardiovascular system. One of the most important systems academically, clinically. Clinically, all the systems are important, of course, but you will find that the clinical subjects have a lot of space given to this particular system. And of course, I know the students, most of the students, whenever they want to buy a new book of either physiology or medicine or pharmac, they will open and try to read the CVS chapter first. So yes, it is quite a favorite system for the students as well. This is in two sections we will discuss it, cardio and vascular. So first section will have the cardiac physiology, and then we will see the circulation, blood pressure, and so on and so forth. So let's begin with the first section, and the first topic, really, the introduction. We will start with introduction and then conducting systems, special junctional tissues of the heart. Now, I know that this particular part is taken even before the students join the medicine. It's taken in 12th standard, and then of course in the first year of medical school. So you may be already aware of various aspects, but still you will find that there are many things that are still conceptually need a lot of understanding, and therefore let's begin. Let's start with the introduction part first. We'll see the properties of the heart, properties of the cardiac tissue. So this is a very basic thing. The cardiac tissue shows excitability. You know, there are two tissues in the body which are excitable. Their membranes excite: nerve and muscle. And in muscle, all types of muscles. So membrane excitation. Since it's a muscle, cardiac muscle, it shows an additional property of contractility. The muscle, heart muscle, contracts and ejects the blood into the circulation. Well, I must say at this point that atria and ventricles, they are contractile chambers, but atria are seen as the primer pumps. They are primer pumps. They prime in a sense, and it's the ventricles which actually pump the blood out. So whenever we say heart, contractility of the heart, myocardial contractility, we will be essentially referring to the ventricles. Then autorhythmicity. Yes, there are many parts in the heart. We will see this in the due course of the discussion, that they excite in a rhythmic fashion, one after the other. Now, how is that different from a skeletal muscle or a smooth muscle? You know, skeletal muscle gets one signal and it contracts once. That's it. Heart muscle, or many regions in the heart, many parts in the heart, they excite in a rhythmic fashion, one after the other, in a very regular and rhythmic fashion. Plus, the word auto means a property of self-excitation. That is, there are many parts in the heart which show a property of self-excitation. Means even if they are not getting any signal from outside in the form of a neural signal, they can still excite themselves. And why is that required? Of course, because there is a pacemaker in the heart. If it stops functioning, then some other part should take over the function of pacemaker and generate the impulses. So it's a very important property for the heart to continue to beat forever. So that's one. And long refractory period. There are some parts in the heart which exhibit this property. Not all parts. Some parts in the heart, for example, Purkinje fiber, ventricular muscle fiber, they will show long refractory period. And for this reason, they cannot be excited at very high frequencies. We will see all this in detail later on. This is just the beginning, the introduction part. Right, so some of the properties at a very basic point. Now, let's see a few more properties which are important functionally. Heart muscle cells are connected by a number of gap junctions. The myocardial cells are connected with gap junctions, and therefore heart muscle works like a syncytium. Okay, very important property. Look, entire musculature in one chamber, it will act synergistically, synchronously, and it will contract together. That's the meaning of syncytium. Let's explain it further. See, the myocardial fibers or myocardial cells are connected with numerous gap junctions. The gap junctions are junctional regions. You can refer to the general physiology section where we have discussed this. The junctional regions where there is free passage of ions from one cell to the next, and therefore the cells are electrically coupled to each other. So free flow of ions from cell to cell to cell and the next cell. And therefore what happens is that if when the impulse arrives at one corner, at one point of the chamber, then it will quickly spread through all the cells. Okay, because of this very rapid transfer of ions from one cell to the next and so on. So impulse, excitation reaching one point, one corner of the chamber, then it will quickly spread into the entire chamber. So that, I'll just give you an example so that you can visualize it. Have you seen an ice tray? If you've ever seen an ice tray in the refrigerator, we pour water from one corner and then that water quickly spreads into that entire tray. Why is that? Because the cells are connected. Okay. Similarly, here the cells are connected, like those cubicles in the ice tray, they are connected. Similarly, here the cells are connected. So impulse coming at one point and then it quickly spreads into the entire chamber. So what is the importance of this? Importance is entire musculature will excite together, and entire together means almost at the same time, and therefore entire musculature will contract together as one bundle. That's very important, because see, otherwise what would have happened is that suppose there are these myocardial cells, take it as a representative diagram, and if the depolarization spreads like this, cell by cell, slowly, then this cell will contract first, then the next, then the next. It will not be effective. Rather, what is happening now is all the fibers, they excite very rapidly at once, and therefore all of them contract together as one bundle, and that makes the contraction very, very effective. Let me ask you a question, and don't mind, because this topic is done in 12th standard and also in first year MBBS. So here is the question. Heart is made up of how many syncytia? Options are 1, 2, 3, 4. Come on, many of you are thinking 1. No. Heart is made up of 2 syncytia. There are 2 syncytia, 2 separate syncytia in the heart. Both atria together work like one syncytium. They will contract together. And both ventricles, they will contract together as another syncytium. Okay, you know this, that all 4 chambers do not contract together. First atria contract pump the blood into the ventricles, then the ventricular contraction starts. So there are two syncytia, atria and ventricles. And remember also there are two pumps in the heart, a right-sided pump and left-sided pump. Right, so that's another property. Now coming to the next, one more, let's say property or characteristic is that there is presence of intercalated discs in the heart. Intercalated discs. What is the importance of these intercalated discs? That they provide electromechanical tethering to the cardiac muscle fibers. The muscle cells are mechanically tethered to the intercalated discs. Why is it needed? It's very simple. Look at the skeletal muscle. I'm just giving a comparative example. Skeletal muscle has a tendon, and tendon is inserted into a bone. So it gives a good kind of gripping effect, and muscle can contract. Whereas in the case of heart is made up of just the muscle cells surrounding a cavity. So in a way, I mean, they would be floating just like that. But no, what happens is there is mechanical tethering given to the fibers so that they can contract strongly and together. So that's the importance of intercalated discs. Right, so that was the introduction. Now let us begin with the main topic, that is conducting system of the heart, also called as special junctional tissues of the heart. You know the parts of the conducting system. Just as a revision, let's draw it here, and I am going to ask MCQ and then I will describe that particular part. This is because, again, as I mentioned, you must have read it already. Okay, so SA node situated in the superior-lateral wall of the right atrium, and then AV node, and there are three internodal tracts sending the impulse to the AV node. Then there is bundle of His, and then the right and left branches of the bundle of His, left branch and the right branch of the bundle of His. And finally, from the apex, there are Purkinje fibers, which then finally merge into the ventricular muscle fibers. Merge in the sense that they will excite the ventricular muscle cells. So this is the conducting system of the heart, the parts of the conducting system. Now, I will ask one MCQ and then I will explain that part. Okay, I'll give you 3 to 4 seconds to just think over the MCQ. It's not very difficult, so let's try it. Let's try that. Okay, first question. Choose the correct statement of the following. This is about atrial excitation. Choose the correct statement. Which atrium excites first? A. Right atrium excites ahead of left atrium. B. Left atrium excites ahead of right atrium. C. Both atria excite together at the same time. Or D. Depends on the size of the atria. What say? Well, some of you are thinking that both atria excite together, right? Wait, hold on. Right atrium excites ahead of left atrium. Look, some time back I told you that both atria work like a syncytium. That's for the contraction. But before that, the muscle has to excite. So please make this distinction very, very clear, that excitation happens first, and as a result of that, the contraction happens. So in the case of excitation, depolarization occurs in the right atrium first, because pacemaker, SA node, is situated in the right atrium. And then it spreads into the left atrium like that. Yeah, so right atrium excites first ahead of the left atrium. One more point. Let me show it in the diagram itself. And let me ask you a question. There are three numbers given in this diagram. 1, 2, 3. So the question is, number 1 shown in the figure is called as what? And the options are Batchman's bundle, Wenckebach's bundle, Thorell's bundle, or Kent's bundle. What say? Okay, it's the Batchman's bundle. So, SA node sends impulses to the AV node via 3 internodal tracks, as you can see in the diagram: anterior, middle, and posterior. Okay, anterior, let's write it here. Anterior internodal tract is called as Batchman's bundle. Middle is called as Wenckebach's bundle, and posterior internodal tract is called as Thorell's bundle. Right? And note this point: one branch of the anterior bundle goes into the left atrium and supplies, innervates the left atrium. So these are the 3 internodal tracts. Okay, I also mentioned Kent's bundle, bundle of Kent. Where is it located? Okay, let's have it as an applied aspect. Bundle of Kent, let's write it here, is an aberrant anomalous path. Bundle of Kent is an aberrant anomalous path that connects atria directly with the ventricles. See, atria connected directly to the ventricles means bypassing the AV node. This is the bundle of, just a representative diagram. It connects atrium directly to the ventricle, bypassing the AV node. And therefore, there is no AV nodal delay. This abnormality is present in a few individuals, and in them, this bundle of Kent, it's an aberrant anomalous path. It bypasses the AV node. So impulse, therefore there will be no AV nodal delay. Impulse from the atrium directly will go into the ventricle. Right? So no AV nodal delay in these individuals. Okay. On the ECG, you will refer to the ECG later on. But on the ECG, AV nodal delay represents as the PR interval, and therefore if there is no AV nodal delay, then on the ECG there would not be PR interval. See, P wave, atrial depolarization, and QR is complex ventricular depolarization, and the duration between the two is because of the AV nodal delay. So, when those individuals who have this bundle of Kent, shortened PR interval, I mean to say that PR interval will be very shortened. Therefore, it gives rise to the so-called delta wave on the ECG. You can see here the PR interval in a normal ECG. We will discuss it later in the ECG itself. And here there is no PR interval, giving rise to the so-called delta wave. Because of the appearance, it's called as a delta wave on the ECG. And this is all seen in the Wolff-Parkinson-White syndrome. Wolff-Parkinson-White, commonly known as WPW syndrome. So that's about the bundle of Kent. Since we were talking about those internodal tracts, I just added a clinical side to it. Okay, now coming to the AV node, and then bundle of His, which starts from the AV node. So here comes the next question. Choose the correct statement of the following. This is about ventricular excitation. Which ventricle excites first? Okay, choose the correct statement. Right ventricle excites first ahead of the left ventricle, or left ventricle excites ahead of right ventricle, or both ventricular excitation starts at the same time. Look, I'm talking about the start of excitation. Okay, right. So let me just rephrase the question. Right ventricular excitation starts first, or left ventricular excitation starts first, or both ventricles begin to excite simultaneously together at the same time, or sometimes right, sometimes left. So what do you say? Okay, the answer is left ventricular excitation starts first ahead of the right ventricle. Let me write it here. Left ventricle begins to excite first. Why is that? Look, you can see in the diagram, from the AV node, bundle of His arises. Now what you should note is, bundle runs a certain distance, but it gives off the left branch first. It gives off the left branch first, and then bundle itself continues downward as the right branch. You can note in the diagram, and therefore impulse enters the left branch first, and therefore we said just now that the left ventricular excitation starts first ahead of the right ventricle, because impulse is entering the left branch first. Remember this. You can see in the diagram, left branch has started from the bundle, and then bundle itself continues downward as the right branch. So then both branches run on either side of the interventricular septum. But impulse went to the left branch first, then through the septum it goes to the right, and then the impulse comes down in both branches toward the apex. So we have already mentioned one point, that left ventricular excitation starts first, and second point that I want to mention is, because of this spread of impulse through interventricular septum, this spread is responsible for the Q wave on the ECG. We will note it when we discuss the ECG in detail, but the Q wave is the first downward deflection on the ECG, and that is because of spread of impulse from left to right through the interventricular septum. You know why it's a downward deflection? It's because the major depolarization wave is spreading leftward and downward. You know, starting from the SA node, the depolarization is spreading toward the apex. So it's going leftward and downward like this. Only this particular wave at the start is going in the opposite direction, and therefore it gives a downward deflection as a Q wave. So please remember this part, the cause of production of Q wave. Right. Next point. Since we are talking of the His bundle of His and its branches, let me ask you one question which has, it's a clinical application. Look, we are saying that the exam pattern has changed now and there will be more and more of a clinical pattern which is going to be asked. Yes, it's true. So how will the clinical pattern be asked? They can, previously the questions would be that what is the normal time duration of HV interval on his bundle electrogram, and they will give 4 options. Okay. Now instead, let me just write it here. We are talking about the his bundle electrogram. They will give you an interval, HV interval. We will discuss it just now. And they will ask you what is the normal HV interval on a normal his bundle electrogram. And there will be 4 options. So you have by hearted and you will answer. Now instead, the questioning will be just a modification. A 50-year-old male was brought to the emergency, and then his ECG and HBE was recorded, and he is a suspected case of RBBB, right bundle branch block. We are talking about the bundle of his and its branches. So right bundle branch block. Which interval will be prolonged on his bundle electrogram? On the patient's his bundle electrogram, which interval is expected to be prolonged? And the options given are PA interval, AH interval, HV interval, or none of the above. So just it has been given a garb of a clinical type question or a problem solving type question, but the basics remain the same. You know the his bundle electrogram, you know the waves and intervals in it. It will be easy to answer. So my point is, never many students tend to give up when they see a long question, 4-5 lines. They think, oh, I won't be able to decipher the meaning and answer this question. No, there is always a hint given in one sentence. Just look for that sentence and you can answer such questions, the problem solving questions or image based questions. Right, let's come back to this part. We are talking about the bundle of his. So there is something called as his bundle electrogram. Electrodes are placed on exposed part of the his bundle and in the right ventricle and right atrium. So somewhere here the electrode on this part, and then electrical potentials going on in the heart are recorded, and that's called as his bundle electrogram. Okay, and it's also correlated with the ECG. So here we have the ECG, P wave, QRS complex, T wave, and now his bundle electrogram, electrical activity recorded from the his bundle, electrode placed over there. It shows these waves: A wave, H wave, and V wave. A wave, H wave, and V wave. So basically 3 waves are seen in his bundle electrogram, and you can note it here that the V wave is a downward deflection, because as I mentioned, electrodes are placed in the right ventricle, whereas the waves are spreading towards left, downward and leftward. We will see that in the ECG, of course, once again, but major spread of waves occurs leftward and downward, whereas we have placed the electrode on the right heart. So since wave is going away from that electrode, it gives a downward deflection. Well, A stands for SA nodal depolarization, H stands for his bundle depolarization, and V stands for ventricular depolarization. Okay, in simple, SA nodal or atrial depolarization, his bundle depolarization, and ventricular depolarization. I am saying atrial or SA nodal because SA node situated in the atrium, right atrium. So these are the waves. And therefore the intervals. First of all, let me tell you what are the indications of His bundle electrogram. Why is it at all recorded? There are two indications. First of all, you have noticed that SA node to His bundle and then ventricle. So, first indication is that in the conditions of heart block, we would like to see where exactly the heart block is located. Above the His bundle or below the His bundle. Above the His bundle means where? Okay, let's see in the diagram. Look, impulse is starting from the SA node, going through the AV node. And what's heart block? Blockade of impulse transmission. It commonly occurs at the AV node or below AV node. Now, as I said, if the block is above the His bundle, means in the AV node, the block of impulse, blockade of impulse. Or if the block is below the His bundle, means in the bundle branches. To differentiate between this, we have to record the His bundle electrogram. Okay. And the second indication is to differentiate between supraventricular tachycardias and ventricular tachycardias. When the focus of that tachycardia is above the ventricles in the atria, it's called as supraventricular tachycardia. And if the focus is in the ventricles, it will be called as ventricular tachycardia. So to differentiate between these two also, it helps. The His bundle electrogram will help. Okay. AH interval. It represents what? The time taken by the impulse to travel from SA node up to the His bundle. And it is 55 to 130 milliseconds. That's the normal AH interval. And HV interval. It represents what? The time taken to travel from His bundle up to the ventricles. And it is, the normal value is 35 to 55 milliseconds. Now, if AH interval is prolonged in a patient, then heart block, the block will be above the His bundle. That is in the AV node, isn't it? If the AH interval is prolonged, that means impulse is taking longer time to reach the His bundle. That means what? The block is in the AV node, above the His bundle. And if the HV interval is prolonged, that means the impulse is taking longer time to go from His bundle to the ventricles. What is there in between these two? The bundle branches. So, in the conditions of bundle branch block, HV interval will prolong. Easy, isn't it? If there is and I asked you the question, right bundle branch block, what do you expect? Which interval will be prolonged? Now the answer is obvious, HV interval. Impulse will take longer time to go from His bundle to the ventricle. Between them, there are bundle branches, and if they are blocked, interval will be prolonged. Okay, and if this is prolonged, AH interval prolonged means there is AV nodal block. Block is at the AV node. Right, so that's the bundle of hairs and its branches. But you have noted this, the left branch arises and the first left branch given out, and then right bundle branch blocked. How is it formed? The bundle itself continues downward as the right branch, and they go, both of them, they go to the apex. From here the Purkinje fiber will start. So Purkinje fiber will carry the impulse like this. So my next question is, we have done so far 2-3 questions. First, to excite right atrium or left atrium, right atrium. Then excitation of the ventricles. Which one is the first one to start? The answer was left ventricular excitation starts first. Now I am going to ask you 2-3 more questions related to this part, the Purkinje fiber ventricular muscle. So my next question is, excitation ends in which ventricle first? Which ventricular excitation ends first? We have said that left ventricular excitation starts first, and then it will spread into the ventricles. But which ventricular excitation will end first? And the options are left ventricular excitation ends first, or right ventricular excitation ends first, or both ventricular excitation ends at the same time, or sometimes right, sometimes left. So what say? Well, the answer is right ventricular excitation will end first, slightly ahead of the left ventricle. You know why? What's the reason? Look, as I mentioned just now, the impulse will travel like this from apex to the base, and the ventricles will be excited. But you know, left ventricle has a thicker muscle mass compared to right ventricle. Okay, left ventricle having a thicker muscle mass means it will take little longer time to complete its excitation compared to right ventricle. Okay, it will take 0.01 second extra to complete the depolarization, complete the excitation. Right. So that's settled. Right ventricular excitation will end first, and left ventricular excitation will end 0.01 second later. In fact, if we were to see what are the timings for the impulses to reach at different points, say impulse starts at 0.00 time, the impulse starts at the SA node. Yeah, that's the 0 time. Then 0.07 seconds, it will reach the AV node. Then it will emerge from the AV node and enter the bundle of his by 0.16 second. So see, it has taken almost 0.09 seconds to cross the AV node. That's the AV nodal delay, and we know the importance of AV nodal delay as well. The impulse transmission is delayed into the ventricles. So atria excite first and ventricles excite after that, and therefore atria contract first and ventricular contraction starts after that. That's beneficial because atria will contract first, pump the blood into the ventricles, then the ventricular contraction will start, which will be effective, right? But that's not the issue. The issue is 0.16 seconds, the impulse will reach the bundle of his. Then 0.19 seconds, it will reach the apex. 0.19, yes. And then look, the base of the heart. Here is the base of the right ventricle. By 0.22 seconds, it will reach the base of the right ventricle and depolarize the right ventricle. And by 0.23 seconds, it will depolarize the base of the left ventricle. So left ventricle has taken that 0.01 second extra to complete the depolarization, and that's because of the thickness, greater thickness of the left ventricle compared to right ventricle. Okay, so we are into the ventricles so far, so I need to ask you one more question. It's not related to the conducting system as such, but let me ask it. We can discuss this question here, no problem. The question is, which ventricular ejection starts first? See how fascinating it all is, the discussion. And in that series, I'm asking you the next question. Look, we have said right atrium excites ahead of left atrium, okay, in case of atria. Then ventricular excitation starts first in the left ventricle and then in the right ventricle. But ending, right ventricular excitation will end first and left ventricle excitation ends little later because a thicker muscle mass. And after this excitation has spread, the contraction, the systole will start. So my question is, ejection of blood will start first by which ventricle? So choose the correct answer. Right ventricular ejection starts first, or left ventricular ejection starts first, or both ventricular ejection starts at the same time, or depends on the condition of the vessel wall. What's your answer? You are thinking that both ventricular ejections start first. Both ventricular ejections happen at the same time. You are thinking that. No. The answer is right ventricular ejection starts first, ahead of the left ventricular ejection. Okay? And why is that? Although this is not exactly related to the conducting system, you can take it as a part of introduction. Look, right ventricle pumps the blood into the pulmonary artery when the pulmonary valve will open, and left ventricle will pump the blood into the aorta when aortic valve opens. Okay, so when the valves open, the ejection will begin. So you need to now note down that the semilunar valves, pulmonary and aortic valves, which valve opens first? Pulmonary valve opens first and aortic valve opens later than that. Little later, it's a question of just milliseconds, but there is a difference. What is the reason? The reason is the valve opening and closure depends on the downstream pressure, the pressure in the vessels. See the valve leaflets, they are going to open like this. Okay, this is the aortic valve and the pulmonary valve. The valve leaflets will open like this and they will close in the opposite direction. The leaflets move down. So this opening of the valve and closure depends on the downstream pressure. Now listen to this part carefully. Pulmonary artery is a low pressure vessel compared to the aorta. So pulmonary valve opening will be easy. Okay, because beyond those leaflets there is a lower pressure comparatively, the pulmonary artery pressure. Whereas aortic valve will open slowly because beyond that there is aorta, which is a high pressure vessel. So valve leaflets will move little slowly. Okay, and therefore please remember, while opening, pulmonary valve opens first because it opens very easily, because beyond the valve there is lower pressure, and aortic valve opens little later. And while closure, the opposite will happen, and that opposite also happens because of the pressure in those vessels. Aortic valve will close first and pulmonary valve will close little later. Okay, why? Because aorta being the high pressure vessel, those valve leaflets, when they are closing, they can close rapidly because now it's in the opposite direction, the movement of the leaflets, whereas pulmonary valve will close little slowly. And so remember, aortic valve closes first and pulmonary valve closes little later, and the closure of these two valves produces the second heart sound. So second heart sound will have two components, aortic and pulmonary. Okay, so sometimes it is referred to as A2P2, and in the conditions like deep inspiration or certain other conditions, what happens is that the sound will split actually, and there will be splitting of the sound that can be heard. However, normally from both these components we get only one sound to be heard, that's second heart sound. All right, that was about the ejection. So the point is, pulmonary valve opens first, so right ventricular ejection starts first ahead of the left ventricle. Okay, although it's quite only of academic importance, but it is a reality. All right, so we are talking about the ventricular excitation now. We have come to the ventricular excitation. We have come to the Purkinje fiber, and let's now discuss the ventricular excitation. So my next question is, and we'll discuss the answer, is last part of the heart to get depolarized is what? Last to depolarize, and the options are, I am now narrowing down the options. The options are epicardium of the base of the left ventricle, endocardium of the base of the left ventricle, apical epicardium means epicardium of the apex, or apical endocardium. Which one is last to be depolarized, since we are talking of ventricular depolarization now? Okay, what's your answer? First of all, we have differentiated between right and left ventricle, so let's stick to now left ventricle, since it's a thicker muscle mass. Even in that, the answer is epicardium of the base of the left ventricle. Last part of the heart to get depolarized is epicardium of the base of the left ventricle. Why? Why I am saying that is because the depolarization, when I say impulse, it will mean depolarization, and I have discussed this extensively in the chapter of nerve muscle. So depolarization, it spreads from apex to base, and at the same time endocardium to epicardium. Okay, so impulse travels like that in the ventricle, apex to base. Let's see it in the diagram. The depolarization spreads from apex to base like this, and at the same time impulse will go from endocardium to epicardium. Okay, endocardium to epicardium like that. So it is going from inside to outside. In fact, it travels like this in a spiraling manner. It travels like this. It's going from inside to outside, and at the same time going towards the base. And so the last to depolarize is epicardium of the base of the left ventricle. So let's just write down last to depolarize are the following parts: epicardium of the base of the left ventricle. Well, there are two more parts which depolarize in the end: pulmonary conus and uppermost part of the interventricular septum. Have you noted it? Uppermost part of the interventricular septum is the last to depolarize. Yes. I will explain the logic and reason, both. First thing is, let's see the reason behind it. I mean, why it's happening like that. Look, we have said just now that impulse goes in the left branch first, then through the interventricular septum it goes to the right, and then it comes to the apex in both the branches. So this part, the uppermost part of the interventricular septum, was left to get excited, and therefore we have said that it is the so it will be depolarized in the end by the smaller branches of the conducting system. So that's the first part, that when the base of the heart is depolarizing, the uppermost part of the septum will also depolarize at that time. Now, what is the logic behind it? I mean, how is it beneficial? Look, after all, interventricular septum is a muscle. It's made up of muscle. Imagine that this septum, the muscle, was the first to excite. You know what will happen then? The depolarization will then go into the ventricles, and then the ventricles will begin to contract. By that time, this muscle will come into relaxation mode, isn't it? Because it excited first. If it excites first, then it will contract immediately. So by the time impulse goes in the ventricle and ventricular contraction starts, the interventricular septum and its muscle will relax. It will become lax. We don't want that to happen. We want that when the ventricles have excited and when they begin to contract, we need an uptight, contracted interventricular septum. And that is made possible by this kind of arrangement. When the last parts of ventricle are depolarizing, that time interventricular septum, the uppermost part, is also depolarizing. So when the contraction starts, the systole starts, the septum will be an upright contracted muscle mass. So last parts to get depolarized are these parts which I mentioned just now. And therefore we have effectively answered that question. Now coming to repolarization. And here again, students tend to confuse. They mix up. And why do they get mixed up? Because they have not understood the concept of depolarization and repolarization. So before I ask you one question and discuss the repolarization part, let me say one sentence or two sentences, and then I'll ask you the question and then we'll discuss it. The question is, depolarization should be taken as a traveling impulse. Okay, it travels. And repolarization should be seen as recovery from excitation. Okay, excitation means depolarization and it travels. It's a traveling wave, it's a traveling impulse, and we saw how it travels just now. What is repolarization? Repolarization is recovery from excitation. Okay, it does not travel, it occurs point by point or fiber by fiber in this case. All right, so that's how you should look at depolarization and repolarization. And with that, I am going to ask the question, last part of the heart to be repolarized is which part? And I give you same four options: epicardium of the base of the left ventricle, endocardium of the base of the left ventricle, apical epicardium, apical endocardium. What is your answer this time? I think most of you are thinking epicardium of the base of the left ventricle because it was last to get depolarized. It will be last to repolarize. No. The answer is apical endocardium. And I'll explain why in detail. Okay. Many students, they refuse to understand this. They refuse to accept this. They are not unable to understand this. So I am saying again, repolarization should not be seen as a traveling impulse. Repolarization means recovery from excitation. It occurs point by point. Don't take it as a traveling wave. It occurs fiber by fiber, cell by cell. So let's understand how come this is possible. Let's just draw a diagram. Well, depolarization goes from apex to base. All right. I'm showing a representative diagram. I've shown some cardiac cells. Please take it as a representative diagram. Okay. I know cells are not lined like this. They don't appear like this. This is just to understand. What I'm saying is depolarization. Let's write depolarization. D. It goes from apex to base. Okay, means cell at the apex is first to depolarize. Clear? But then recovery occurs in the reverse. I told you the answer already. Last part to repolarize is apical endocardium. Why is that? Because repolarization goes in the opposite direction. Means repolarization goes from base to apex and epicardium to endocardium, like that. Epi to endo. So in the reverse direction, and therefore last to get repolarized will be apical endocardium. Let that be clear. So that's the first point. So first to depolarize will be last to recover. Okay. Now the question is, why? How come this is possible? Look, very obvious question. If this cell was the first to depolarize, first to excite, then what I'm saying is that then the depolarization goes to the base. The cell at the base will depolarize, then it will repolarize also, and repolarization will occur in the reverse, and then it will come back like this, and this will be the last to repolarize. So my question, if this was the first to depolarize, then what was it doing all this while? That the depolarization went to the base and then repolarization came back in the reverse, and this will be the last to repolarize. What is it doing all this while? If it is the first to depolarize, it should have repolarized also. What is it waiting for? That's the question. That's the moot question, and therefore that will be answered just now. Look, cell at the apex is first to depolarize, means it is first to begin to depolarize, but it does not complete its depolarization first. Can you understand this? It's the first to begin to depolarize, and then depolarization goes on further toward the base like that. Okay, so it begins to depolarize first, but it does not complete its depolarization. Okay, it did not complete the depolarization. And then meanwhile, depolarization is also spreading like a wave. These cells are connected by gap junctions and ions are spreading very rapidly. So it will go to the base. The cell at the base, the fiber at the base, the moment depolarization reaches here, it will instantly complete its depolarization and it will begin to repolarize. Okay. By that time, previous fiber has completed the depolarization. So it will begin to repolarize. By that time, the previous fiber. By that time, the previous fiber. So recovery is occurring fiber by fiber by fiber in the reverse because they are completing their depolarization at different times. Okay. So you can now tell me a quick fire question. Fastest depolarizing cell in the ventricle is which one according to you? We have discussed just now. The cell at the apex or mid portion or at the base? Base, yes, because the moment depolarization spreads there, it most rapidly completes its depolarization and begins to recover. Then the previous cell, then the previous cell, and then the previous cell. And cell at the apex is last to complete its depolarization and therefore it will last to repolarize and recover. Okay, so that is how this is possible, that depolarization and repolarization can spread in the opposite directions. So let me just show it diagrammatically to make you understand this further. Here is the cell at the apex. First, look at the depolarization. I'm just making it little exaggerated, this slope of depolarization, so that you can understand the difference. This is the cell at the apex. Look how much time it is taking to complete the depolarization. It starts here and it's completed somewhere at this point of time. It is taking this much time to complete the depolarization, and during this much time all those things are happening, depolarization going to the base and recovery occurring in the reverse, fiber by fiber. And as you go into the ventricle further toward the base, the rates of depolarization will be rapid and rapid and rapid, like this. Okay, look, basically all these cells in the ventricle, they are rapidly depolarizing, but in that also the rates are different. That's the point I'm making. And finally, fiber at the base will be the most rapidly depolarizing cell. The moment depolarization wave reaches the base, that cell will very rapidly complete the depolarization and it will begin to repolarize, and then it will happen in the reverse. So this is why that can happen, that depolarization and repolarization can go in the opposite directions. Okay, but that's what I'm saying, that just keep this in mind always as a concept, that take depolarization as a traveling excitation or traveling wave, a traveling impulse, and take repolarization as recovery from that excitation. And don't consider repolarization as a traveling something. Consider repolarization as occurring point by point by point. Okay, or cell by cell by cell. Don't take it as a wave. Then you can understand all these things. Okay, let me finally just add one more point in this. Now this is interesting. Okay, I am further strengthening your concept. Look at the ECG now. We are still on this point only. Depolarization and repolarization going in the opposite. ECG has this appearance. PQRST waves. QRS complex represents ventricular depolarization and T wave represents ventricular repolarization, right? If you have done ECG before this, you will know what I am saying. Now, ventricular depolarization and ventricular repolarization, they both are upright. They both are in the same direction. How is that possible? Look, when we record action potential from one point of the nerve, the graph appears something like this. So if the depolarization is upstroke, repolarization is downstroke, isn't it? Yeah, that's the action potential from one point of the nerve. That means depolarization and repolarization should get recorded in the opposite directions. Why? Because they are electrically opposite types of events. Simple. Depolarization and repolarization are electrically opposite types of events. Inside becoming positive, then inside again become negative. So that's that. They are opposite types of events. So they should get recorded in the opposite directions. That is what happens in the nerve at one point of the nerve. This is the graph. And what do we see here? Ventricular depolarization, upright. Ventricular repolarization, also upright, means in the same direction. Why is that? Now you will understand. Depolarization and repolarization are electrically opposite types of events, and in the heart they are spreading also in the opposite directions. Opposite types of events, and they are spreading in the opposite directions as well. So it's like two minuses cancelling out to make one plus. I mean, just for an example, but then they cancel out the those two minuses, and therefore finally the QRS and T wave get recorded in the same direction. Both are upright. Okay, so I have told you the physiology behind it. I have told you, explained the logic behind it, the logical explanation as well, right? So last part of the heart to get repolarized is apical endocardium. I'll ask you the next question. We have almost finished one part of this discussion, conducting system. I wanted to discuss the conducting system as in its parts and how impulse is conducted. We have a lot more to discuss, including the arrhythmias. So we'll take that in one more section, conducting system part 2. Okay, but before we go to that, I'm just finishing this particular part by asking the last question. You know, SA node is pacemaker. Yeah? SA node is the pacemaker. Impulses generate at the SA node and they are sent into the ventricles, sent into all parts of the heart. But the question is, SA node is pacemaker because of what? Because of what? And I'll tell you the 4 options. You need to choose the correct one. Of course, I'll help you there and then we'll discuss it. SA node is pacemaker because of one of the following options. Options are slow depolarization and slow repolarization of the SA nodal cells. Rapid depolarization and rapid repolarization of the SA nodal cells. Slow depolarization and rapid repolarization, and the last option obviously would be rapid depolarization and slow repolarization. So which one of them is the correct answer according to you? I know most of the people, because of the wrong concept, they tend to go with B, rapid depolarization and rapid repolarization. Everything is rapid for the SA node, that's why it's a pacemaker. No, that's not the correct answer. So what do you think? Which property is making it the suitable candidate for becoming the natural pacemaker? The answer is slow depolarization and rapid repolarization. Yes, SA nodal cells are slowly depolarizing and rapidly recovering cells. So, let me just explain this and then we go to the next section of this particular chapter. Let's first finish this part. Look, rapid repolarization. Yes, that is a property of SA node. You know, in fact, fastest repolarization. Because imagine, first impulse starting at the SA node and depolarizing all parts of the heart. Now, before any other part could repolarize, recover and begin its own excitation, SA node recovers, repolarizes first and it generates the next impulse. It will go down and excite all parts of the heart. So, rapid recovery, I mean a part can be pacemaker if it recovers most rapidly. So, it does not allow any other part to recover and excite by itself. Before that, the SA node recovers first, fastest, and it generates the next impulse. It sends it down. And slow but spontaneous depolarization to threshold after every repolarization. See, it's like this. Why is there the autorhythmicity? That this is the action potential in the SA node. So, at the end of every repolarization, the SA nodal cells again slowly but spontaneously begin to depolarize and reach threshold all by themselves. Okay, so that's why they have this autorhythmicity property. Slow but spontaneous depolarization at the end of every recovery, every repolarization. All right. So that should give you the idea of the question. Most rapid recovery and after that slow but spontaneous depolarization to threshold. That's what makes the SA node the pacemaker. So you must have understood by now that although you have read the conducting system, there are still many parts which are to be explored. So let's begin to explore those parts further. We will take the things from here onward, and the section 2 will deal with the action potentials in various parts and how they appear, what are the ionic basis of those action potentials, and what are the various bases for arrhythmias, and so on and so forth. So that will be the second section. Let's start with that second section. Just now we have said that SA node has this action potential. So let me continue with that only. Since we are talking about the action potentials in the heart, there are two types of cells in the heart. And by that, I mean there are two types of action potentials in the heart. Let's begin with the action potentials in the heart. Two types. First type of cell is called as slow response type. And by slow response, when we say slow response type, it means slowly depolarizing cell. Slow response type. And the other type of action potential or other type of cell is fast response type or rapidly depolarizing cell. Okay, so it should be clear that when we say excitation, membrane excitation, it means depolarization. Under normal circumstances, SA node and AV node are the slow response type cells, slowly depolarizing, and we have seen some part of it just now. Whereas fast response type, the Purkinje fiber, the ventricular muscle fiber, these are all fast response type. They are rapidly depolarizing. What is the difference? The difference is the slow response type cells, they are their RMP is less negative, minus 55 to minus 65 millivolts, and they can reach the threshold easily because it's very close to threshold. Whereas fast response types, their RMP is more negative, minus 90 millivolts. So naturally the amplitude of action potential also will be less for SA node and AV node, and large amplitude in the case of Purkinje fiber, because it is going to depolarize from minus 90. From minus 90 to plus 35 will be a larger amplitude compared to this. Right. These are the two types of cells. Now I am going to draw the two action potentials. Let's compare these, slow response and fast response, SA node versus Purkinje fiber. And I need your complete focus, okay, to understand this. Otherwise, you will not get the concept. So please focus. Let's see the slow response type first. Okay, here we go. SA nodal cell. Slowly reaching the threshold and depolarization. Slowly reaching threshold and depolarizing. Okay, that's the SA nodal action potential. Now the fast response type. It starts from minus 90. Yeah, we've seen that already. This is from minus 55 to minus 65, the RMP, whereas the Purkinje fiber from minus 90, and fast depolarization. Okay, I think we will have to draw it again just to have a better clarity. So I'll draw it once again. Here is the SA node, slowly reaching the threshold and showing the depolarization. Slowly reaching the threshold and depolarization. Right. So these are the SA nodal action potentials, starting from minus 55 millivolts, and Purkinje fiber starting from minus 90 and rapid depolarization. That's shown in the red is the Purkinje fiber. Now I need you to understand 2-3 things in this. Let's try to understand the points one by one. First point is, look at the durations, action potential durations. SA node a few milliseconds, whereas Purkinje fiber 200 to 300 milliseconds action potential duration. Second point that you should note is that, now note this point and try to understand. In you can see here, in one action potential of the Purkinje fiber, I have shown two action potentials of the SA node. Can you see that? Yes. Now you will ask me, sir, does that mean SA node sends two impulses and ventricle excites once? No, not at all. Not at all. This is just a comparison of two action potentials. Okay, don't get confused at all. SA node sends one impulse and Purkinje fiber excites once. That's how it is, obviously. I mean, that's what happens in the heart. This is just a comparison of two action potentials and their time durations. So first, look at the time durations of two action potentials. Why I am showing this? Overlapping it, compare it. So The point that I am trying to make is, now listen to this part carefully, okay? Don't miss it. The natural rhythmicity of the SA node is twice that of the Purkinje fiber, or let me put it the other way around. The natural rhythmicity, the natural excitability of the Purkinje fiber is half that of SA node. That is what I want to show it to you. That's why I have shown the two action potentials together. Okay, don't confuse and say, sir, two action potentials of 2 SA node and Purkinje fiber excites once. No, not at all. I'm not saying that at all. Please focus. Look, what I'm trying to say is, we have said that each part of the heart has a certain natural excitability, natural rhythmicity with which they can excite. Okay. Here, by this diagram, I want to say that the natural rhythmicity of the Purkinje fiber is only half that of SA node. Look, it is, suppose SA node is generating 80 impulses per minute. All parts of the heart will have to excite 80 times per minute. There are no two ways about it. But they are not exciting with their natural excitability. Their natural excitabilities are less as compared to SA node. Okay? Suppose you are in a classroom and the teacher is teaching with a certain speed. Teacher being the pacemaker. All of you will have to pick up that speed, even if that is not your natural speed. Okay, everybody will have a different speed to pick up the things, to write. But the pacemaker is giving the impulses to all. So all of you will have to go with that speed. Alright? But when you go back home, then each person has its own speed, isn't it? That is their natural speeds to follow. So similar thing is what I am trying to explain. Each part in the heart has got a different natural rhythmicity of excitation, but all of them normally all of them have to follow SA node as the pacemaker under normal circumstances. Now imagine Purkinje fiber has the natural excitability, natural rhythmicity, which is only half that of SA node. Means if the SA node's natural excitability is 80 times per minute, Purkinje fiber's natural excitability, natural rhythmicity is only 40 times per minute. Normally in the heart, SA node will generate 80 impulses and therefore Purkinje fiber has to follow it. It has to also excite 80 times per minute. But if the SA node fails and if the Purkinje fiber, it comes on the Purkinje fiber to become the pacemaker, like you all go home, now you are at your natural excitabilities. There is no more pacemaker to look after you, to give you the nodes. So like that, SA node fails, now Purkinje fiber is the pacemaker. What will then happen? Now the Purkinje fiber will come to its natural excitability, that is 40 times per minute. Then the heartbeats will be only 40 times per minute. You get the point? So that is the point that I wanted to make here. The first and a very crucial point in this diagram is that each part in the heart have their different natural rhythmicities. Means how many times in a minute they can excite. They have a natural tendencies. Each of them are different. In the heart, they have to obey the SA node. Okay. So if the SA node excites 80 times per minute, all parts will excite 80 times per minute. Heart rate will be 80 per minute. But if some other part becomes pacemaker, like in this case I told you, Purkinje fiber, then the heart rate will be 40 times per minute, because that is the natural rhythmicity of Purkinje fiber. Okay, so that was the first point which I wanted to make. And the second point in this diagram which you must note is the slope of phase 4. a very crucial point in this particular diagram. The slope of phase 4. This you must understand because this will come in pharmacology when some drugs will act on the phase 4. This will come in medicine when arrhythmias will discuss slope of phase 4. So look at the Purkinje fiber action potential. Phase 0, this, the rapid upstroke. Phase 1, early repolarization. Then phase 2, plateau. Phase 3, repolarization. And then phase 4 is RMP. So compare the slope of phase 4 in the SA node. Look, this part and this in the Purkinje fiber. So phase 4 is flat in the Purkinje, but it is steep in the case of SA node. What is the significance of that? The slope of phase 4 determines the automaticity of that part. Automaticity of that part of the heart. It depends on the slope of phase 4. I mean, look, the slope, this phase 4 in the SA node is steep. It means what? At the end of repolarization, it spontaneously reaches threshold and depolarizes again. That provides the automaticity. In the Purkinje fiber, the phase 4 is flat. That means the repolarization ended, then it cannot excite by itself once again. Purkinje fiber can excite for one more time only when the SA node sends the next impulse. Because its slope of phase 4 is flat. It cannot excite by itself again. So Purkinje fiber under normal circumstances does not show automaticity or autorhythmicity under normal circumstances because of the slope of phase 4. That also the second point which I wanted to discuss in this diagram. This phase in the SA node versus this phase in the Purkinje fiber. And I have already mentioned this, that the slope of phase 4 is the one which determines the automaticity, whether a fiber will be automatic or not. The autorhythmicity or automaticity, it will depend on this. Okay, but that's not all. Under certain circumstances, the slope of phase 4 can increase in the Purkinje fiber as well. Under certain circumstances, and if that happens, then the Purkinje fiber, look, this is the slope of phase 4 normally in the Purkinje fiber, phase 4. Under certain circumstances, this can happen. Slope will increase. Which means what? Which means at the end of repolarization, or repolarization is not even completed, and it will again begin to depolarize and threshold. That can happen. So that Purkinje fiber it will become automatic fiber. This will result in arrhythmias. Because there can be multiple pacemakers, or there can be multiple fibers which are exciting all by themselves. That will result in arrhythmias. Okay, so that's the first pathophysiologic basis for arrhythmias. Let me just add here, under what circumstances this is likely to happen? Slope of phase 4 can increase in the Purkinje. Under what circumstance? There are various things like ischemia, hypoxia, drugs and poisons like tetrodotoxin. Tetrodotoxin is a poison for fast sodium channels. So these can lead to increase in the slope of phase 4. Like that. Means a spontaneous depolarization to threshold at the end of repolarization, or repolarization was not even completed. I'll just explain any one factor. Let's say ischemia. If there is ischemia in the ventricle, in the Purkinje fiber, you know, even if whenever there is ischemia or hypoxia, first thing to be damaged, first thing to be hit is the sodium potassium pump. So there will be failure of sodium potassium pump. And if the sodium potassium pump fails, what is the job of sodium potassium pump? Send 3 sodium ions out and send 2 potassium ions from outside to inside. Now this pump is failing because of ischemia. Suppose there is myocardial ischemia, infarction, and this sodium potassium pump is failing. So this potassium which was supposed to be brought back into the cell by the sodium potassium pump, that will not happen now. Okay, that means potassium will start rising in the ECF. Failure of the sodium potassium pump. So potassium starts accumulating or rising in the ECF. It can't come back in. So it starts lining just outside the membrane. Right? It starts lining outside the membrane. And because these positive charges, they start lining outside the membrane. Look, we were talking about the repolarization which was happening. Isn't it? A repolarization was happening. So potassium was actually going out. You know, potassium exit causes repolarization which was happening. And then this ischemia has happened and sodium potassium pump has failed. So what happens is potassium which was going out to cause repolarization, that also cannot happen now. Because already positive charges have lined up. There is an electrical gradient which has been created in the opposite direction. Look, potassium goes out by concentration gradient, isn't it? But now the potassium has started accumulating outside the membrane. So more positive charges outside the membrane compared to inside. That means an electrical gradient has been created from outside to inside, means in the opposite direction. So because of this opposite force, the potassium which was supposed to go out and cause repolarization, that will not happen. That will stop abruptly and potassium will start accumulating inside the membrane. Okay, the potassium which is at the core of the cell, it was supposed to go out of the cell and cause repolarization. That will not happen. From the core, it will just come near the membrane but won't go out, because there is an opposing force which is pushing the potassium back into the cell. That opposing force is electrical gradient. So, and all that has happened because of this failure of the sodium potassium pump. So potassium starts rising in the ECF. Therefore, electrical gradient got created in the opposite direction. Electrical gradient from outside to inside, means in the opposite direction to that of the concentration gradient. So intracellular potassium now comes near the membrane and starts accumulating inside the membrane. And potassium coming near the membrane, intracellular potassium coming near the membrane means what? Membrane begins to depolarize, isn't it? After all, what is depolarization of the membrane? Positive charges lining up on the inside of the membrane. So potassium coming, intracellular potassium coming near the membrane means membrane begins to depolarize. Yes, look at that. The repolarization could not be completed because potassium could not go out, and the next depolarization started for the membrane because potassium, instead of going out, just started lining up inside the membrane. So that will create that automaticity. So now you know why in myocardial ischemia and infarction there is arrhythmias and sudden cardiac death. It's because of this. It's arrhythmias. And it may lead to cardiac standstill as well. So cardiac arrest and all that as a consequence of this. Right, so the point that I was making was slope of phase 4, which can increase in these conditions like ischemia, hypoxia. Please remember these phases as well, 0, 1, 2, 3, 4. Since we are talking about the pathophysiologic basis for arrhythmias, I am writing it on the side. There are 3 pathophysiologic basis for arrhythmias. What I am trying to say is, there are various types of anemias, okay, various reasons for anemias, multiple ways that the anemia can occur. But at the basis of those arrhythmias, there are only 3 bases. One of these 3 bases are there for arrhythmias. So 3 pathophysiologic bases for rhythm disturbance and arrhythmias. And we have seen the first of it, which is enhanced and abnormal automaticity. Enhanced and in fact abnormal automaticity, which we saw just now actually, that the Purkinje fiber got enhanced automaticity, which was abnormal. It was not supposed to have that slope in the phase 4, but it got it, and Purkinje fiber became automatic. SA node is generating impulses. There were multiple auto excitations. So arrhythmia. Second one, and I told you this type of arrhythmia is caused by what? I mean, ischemia, hypoxia, all that can lead to this. Second pathophysiologic basis for arrhythmias is triggered activity. Triggered activity. Abnormal action potentials get triggered by themselves. Okay, SA node is sending the impulse, and suddenly Purkinje fiber gets triggered action potential. Yes, that can happen, and that will also lead to arrhythmias. We will see this later in the form of early after depolarizations and delayed after depolarizations. So abnormal activity got triggered in the presence of pacemaker. So, multiple excitations and arrhythmias. And the third basis is re-entry of impulses and circus movement. Re-entry and circus movement. That's the third reason for arrhythmia. So, there are only 3 pathophysiologic bases for arrhythmias. When arrhythmia happens, the pathophysiology is one of these 3. We have seen the first one. We will discuss the other 2 in the due course of the discussion. But remember these 3 things. So moving on further, since we are talking about the action potentials in the heart and the depolarization and repolarization. So the next small segment is, we need to understand what is determined by the rate of depolarization and what is determined by the rate of repolarization. Because if you observed the diagram, the graph, you see SA node and AV node, they show this property of slow depolarization, but slowly depolarizing cells are repolarizing rapidly. And look at the Purkinje fiber. Its depolarization is rapid, but its repolarization is prolonged. The recovery is slow. So then the next question that comes up is, what depends on the rate of depolarization? What depends on the rate of repolarization? So that's the next small discussion. Let's see first, what is decided by the rate of depolarization? What is determined by the rate of depolarization? I have been saying this since the general physio and nerve muscle. If you remember that the impulse means depolarization. When we say impulse is traveling, it's the depolarization which is traveling. Okay. So what is then decided by the rate of depolarization in any part? Rate of depolarization decides the impulse conduction speed. conduction speed of one impulse is decided by the rate of depolarization of any part or the cells in that part. I mean, impulse generated at the SA node, how fast or slow it will go through one part, that will depend on what is the rate of depolarization of those cells. Okay, imagine SA node and AV node. All cells in these two, they are slowly depolarizing cells. If each cell is slowly depolarizing cell, that means impulse will go through these parts slowly, because the ionic movement itself is slow. And Purkinje fiber, all cells in the Purkinje fiber are rapidly depolarizing cells. So if the cells are rapidly depolarizing, ionic movement is rapid, the impulse will go through that part rapidly. So impulse conduction speed depends on the rate of depolarization of those cells in that particular part of the conducting system. Let's see the part and conduction speed. In meters per second, we will see the conduction speeds of various parts. SA node 0.05 to 0.1, AV node 0.05 to 0.1, bundle of His 1 meter per second, and Purkinje fiber 1.5 to 4 meters per second. As I mentioned, rapidly conducting part, Purkinje fiber. Why? Because each cell is rapidly depolarizing. Ionic movement is rapid. Okay, so 2 quick MCQs on this. We have already got 4 options. So look at the options, give me the answer. First, fastest conducting part in the heart is SA node, AV node, bundle of His, Purkinje fiber. The answer is obvious, Purkinje fiber. Second question is tricky. Slowest conducting part in the heart is which one? SA node, AV node, bundle of His, Purkinje fiber. Answer is AV node. The question is why? I mean, the speeds are given almost the same. Then why do we say AV node is the slowest conducting part? I know you are thinking of AV nodal delay. You are telling me the logic behind it. I am asking the physiology of it. Okay. Yes, there has to be AV nodal delay so that the impulse delays going into the ventricles. So AV node has to be the slowest conducting part. That's the logic behind it. But what is the reason behind it? Okay, or the physiology behind it? Well, okay. The physiology is this. AV node is slowest conducting part because in addition to the fact that each cell in the AV node is slowly depolarizing and therefore ionic movement is slow, in addition to that, AV node shows 2 more properties, 2 more characteristics. One is least diameter of the fibers. Fiber diameter is the least one in AV node. You know, if the diameter is less, there will be resistance for the flow of ions through the cell. As in the case of the neurons, the nerve fibers, axons, large diameters are rapidly conducting because ionic flow becomes rapid. Resistance will be less for the flow of ions. And the second one is even more important, least number of gap junctions. Remember, we have done this at the start, that there are gap junctions between cells, and more the number of gap junctions, faster will be the spread of charges from one cell to the next. AV node has lowest number of gap junctions between the adjacent cells, And because of these reasons, AV node is the slowest conducting part in the heart. So that was what is determined by the rate of depolarization. Next, what is determined by the rate of repolarization? We have already said that repolarization should be seen as a recovery from excitation, right? So, if a part is rapidly recovering from every excitation, that means it can generate more number of excitations per minute. It can be excited at a higher frequency per minute. And if a part is taking longer time for repolarization and recovery, then it can be excited at lower frequency per minute. Its natural rhythmicity will be lower. So, rate of repolarization of any part in the conducting system, it determines the natural rhythmicity of that part, natural excitability of that part. I have said this a number of times now that SA node is the pacemaker, so all parts in the heart have to follow the frequency of SA node under normal circumstances, but their natural rhythmicities are different. Their natural excitabilities are different, and that depends on the rate of their repolarizations. As I mentioned just now, that if a part recovers slowly, then it can be excited less number of times per minute. It is taking longer time for recovery from each excitation. So let's see the parts and their natural rhythmicities. SA node, the natural rhythmicity in terms of number of excitations per minute. SA node 80 to 100 per minute. AV node 60 per minute. Whereas Purkinje fiber 15 to 40 per minute. These are their natural rhythmicities. Okay. Now I need to tell you of 2-3 things based on this particular table. First point, actually we have already mentioned it, that the natural rhythmicity of Purkinje fiber is about half that of SA node. So if the Purkinje fiber becomes the pacemaker under circumstances, then the heart rate will be half or even less than that. That's the first part. Second point, which is now you should be able to answer this question very easily. The fastest repolarizing part in the heart is obvious. SA node, fastest repolarizing part. Yes, because it is fastest recovering, repolarizing, therefore it can no other part in the heart gets a chance to generate its own rhythm or own excitation. Before that, any other part excites. Before that, the SA node will excite, and means because it recovered fastest. So that was the second point that I wanted to mention. Third point, what is the reason for arrhythmias in bradycardia? What's the reason that bradycardia may lead to arrhythmias? Answer is again in front of you. Just define bradycardia. Heart rate below 60 per minute. So imagine this. If SA node generates less than 60 impulses per minute, what is likely to happen? Then AV node will get a chance to come to its natural rhythmicity. Because see, normally SA node was recovering fastest and then generating the impulse, and therefore not giving the chance for AV node to become the pacemaker. AV node has that autorhythmicity, just like SA node. We have seen that their action potentials are similar. But if SA node becomes slowed down, then AV node will come out of its suppression, and AV node can go into self-excitation mode, and then it might result in arrhythmias. So bradycardias are also dangerous. They can lead to arrhythmias because of this reason. And the third point which I wish to mention here is that there was an MCQ like this. After cardiac denervation, what will happen to the heart rate? That was a question. The options are increase in the heart rate, no change in the heart rate, decrease in the heart rate, or extremely variable heart rate. Look, I have mentioned this again and again that such MCQs were asked in the past. Now they will be given a garb of clinical or problem solving MCQ. A patient had come for the surgery and the denervation of the heart was performed. So what will be the result of something like that? Yeah, so what's the answer? After cardiac denervation, what will happen to the heart rate? Heart rate will increase. Look, normally heart is predominantly under vagal tone. SA node is innervated by the vagus. There is a vagal tone on the heart and on the SA node, particularly SA node, AV node. And therefore, what happens is, see, the natural rhythmicity of the SA node is 80 to 100 per minute. Let's say 100 times per minute. So if SA node is left to itself, then it will generate 100 impulses per minute. But because vagus is innervating the SA node and vagus is hyperpolarizing the SA nodal cells to a certain extent, vagus releases acetylcholine and it is inhibitory to the heart, inhibitory to the SA node. So SA node slows down under the influence of vagal tone and it generates 70 impulses, 75 impulses per minute. If there is cardiac denervation, that means vagus nerve was cut, then the SA node will come out of that influence. It will come to its own natural rhythmicity of 100 per minute. Heart rate will increase. That inhibitory effect of vagus will be gone. So that was a small section about the depolarization and repolarization rates and what depends on those rates. Now, having discussed all this, finally we will discuss the ionic basis of action potentials in the heart. There was an image based question that they had given the action potential of the SA node and they had given the numbers like this: 1, 2, 3 and 4 and 5, and number 4 in the graph is caused by which current or which ion? That was the question. Fast sodium channels, or rather sodium current, potassium current, calcium T current, calcium L current. So calcium T is the answer for number 4 in the given graph. Such questions can be asked. So let's see. Ionic basis of action potentials in the heart. Starting with the slow response type. SA node. Here is the action potential in the SA node. And instead of giving 0, 1, 2, 3, 4, 5, 0, 1, 2, 3, 4, the numbers that are given for Purkinje fiber, I am using some other numbers. So please be clear on that. Just to have a clear-cut idea, I am starting with repolarization because we need to understand what happens at the end of repolarization. Okay. So I am putting the numbers slightly differently for these phases. I am starting from this phase, repolarization. repolarization that's caused by potassium exit, potassium going out by concentration gradient. Then you can see here the next depolarization has started, so I'll give you the numbers as 2, 3 and 4, and then let's call it this as 5. So phase number 2 means what? The repolarization has ended and next depolarization has started. Phase number 2. It is caused by what? Okay. Potassium exit stops and potassium starts accumulating inside the membrane. Yes. So membrane begins to depolarize again. Look, potassium was going out by concentration gradient. So it carries the positive charges to the outside. Those positive charges line up on the outside and they create the electrical gradient. So further potassium exit will stop and potassium will start coming near the membrane but won't go out. It will just accumulate inside the membrane and the membrane will again begin to depolarize spontaneously by itself. Do you remember this? We have seen somewhere else in some other context. Yes, ischemia, hypoxia, Purkinje fiber will behave like this. We saw that inhibition of the sodium potassium pump and Purkinje fiber becomes automatic by the end of repolarization. This happens and it starts depolarizing again by itself. Right? So that happens in ischemia or other such conditions in the case of Purkinje fiber, but it happens naturally in the case of SA node. So it shows autorhythmicity. But remember, under those circumstances, I think I have not mentioned it there, under the circumstances of ischemia, hypoxia, the drugs like tetrodotoxin and all, the fast response type fiber can get converted into slow response type and can become the pacemaker also if required. So just remember that one point. Okay, so potassium starts accumulating and therefore the next depolarization has started. Then that depolarization will be sustained further by another cation, which is the sodium. So this is caused by sodium current, but we call it sodium funny current. Influx of sodium happens through HCN channels. Hyperpolarization activated, cyclic nucleotide gated. That's HCN channels, sodium channels. They were called funny because the research workers, when they performed the research on these channels, what they found was two things. One is this is equally permeable to sodium and potassium, and the second, in fact the funny part was, more the hyperpolarization of the membrane, more was the activation of this channel. That's funny because sodium generally channel it gets inhibited when the membrane is hyperpolarized. But when the research workers were performing the research and they hyperpolarized the membrane, they saw that the channel is getting more and more activated. So they called it a funny sodium channel. Sodium influx will happen from this through this channel. And number 4 is reaching of threshold. Well, the reaching of threshold is caused by calcium influx through calcium T channels. T stands for transient. Transient inward calcium current will be responsible for reaching of threshold. And then above threshold, depolarization will be completed by calcium, but it's the different channel, calcium L channel. L stands for long lasting. So long lasting calcium current will be responsible for completion of depolarization. And therefore what you need to observe here is the major current for depolarization in the case of SA node It's not sodium, it's calcium. Please note this point. In the case of Purkinje fiber, though, the answer would be sodium, but here it's the calcium. Right. Let's now see the fast response type action potential, like the Purkinje fiber action potential. So Purkinje fiber action potential, what is the most obvious thing that is different in this graph? The plateau. Correct? Yes. Let's understand this. Phase 0, phase 1, phase 2, phase 3 and phase 4. Phase 0 is rapid upstroke. This is caused by fast sodium channels. Tetrodotoxin sensitive fast sodium channels. So fast influx of sodium and a rapid depolarization will be seen. Of course, but the shape is not exactly the same for all fibers in the ventricle. We have seen that part also. Every fiber, although it is rapidly depolarizing, but it takes different time to complete the depolarization. We have seen that. Then phase 1, early repolarization. That is caused by potassium exit. So outwardly rectifying potassium channel and the potassium starts going out. Then phase 2 is caused by plateau. Phase 2 is called as plateau. The flat portion. Plateau. This is caused by slow calcium channels. Slow calcium channels. They were slow to open and they are slow to close. So they have opened now and there is a slow inward calcium movement. I just need to add a point here. Look, we are interested in having a long action potential in the Purkinje fiber. Okay, we don't want its rhythmicity to be very high. So we want a long action potential. We want a long refractory period. So this slow calcium influx helps. How? Imagine if the calcium were to come in very rapidly, if the calcium comes in, and calcium is a divalent cation, so it will bring in lot of positive charges very rapidly into the cell. And what will be the result of that? It will create an electrical gradient that will drive the potassium out very rapidly. And the repolarization will be happening very, very rapidly, very soon. It will be completed. We don't want that to happen. We want that action potential and refractory period of the heart remains longer. So plateau and this long recovery is helped by the slow calcium channel, slow inward movement of calcium. It does not cause a very rapid build-up of positive charges inside the cell. Right, so plateau caused by slow calcium channels. And then phase 3 and phase 4. Phase 3 is now the calcium channels have closed. So potassium exit will continue and repolarization will continue, and phase 4 will be RMP. I want to take you back to the pathophysiologic basis for arrhythmias. First reason or first basis we saw was enhanced automaticity, increased slope of phase 4. That results in arrhythmias, and the reasons also we saw ischemia, hypoxia, etc. The second was triggered activity. Triggered activity means some abnormal action potential is triggered in some part of the heart. That also can lead to arrhythmias. So now we can discuss it here. Triggered activity. Now, first of all, the triggered activity results in what is called as after depolarizations. After depolarizations. After depolarizations can be shown in the action potential graph like this. Suppose this is a normal one action potential of the Purkinje fiber, and the second depolarization should have come here, second depolarization. But suppose that second depolarization occurs at this point of time or over here. Actually, first of all, this is called as after depolarization, which is a misnomer, because this depolarization is occurring before its time. So ideally it should have been called before depolarization, but it is somehow, as a misnomer, it is called as after depolarization. If it occurs early in the phase 2 or early part of, it occurs in the phase 2 or early part of phase 3, then we call it EAD. After depolarizations are of two types, like EAD, early after depolarization, and if it occurs in the phase 4, it's called as DAD, that is delayed after depolarization. So an abnormal action potential got triggered, and this action potential, an extra action potential which has got triggered before its time, it results in something called as extrasystole. An extrasystole can happen. So this is one more pathophysiologic basis for arrhythmias. There are drugs that cause these extrasystoles. Now the question is, which are those drugs which can cause these extrasystoles? Digitalis. The drugs that elevate sarcoplasmic calcium, drugs that increase intracytoplasmic or sarcoplasmic calcium, they can cause such extrasystoles, right? Why? Now look, the calcium that comes in during plateau. Now I would like you to go back to the excitation contraction coupling in the heart. If you can refer to that segment, we have done that. There I have mentioned that ECF calcium goes in and causes further release of calcium in the sarcoplasm. Okay, now this ECF calcium that is going in, look at this point very, very carefully, and you can refer to the EC coupling of the cardiac muscle. We have discussed it extensively there. ECF calcium comes in and causes further calcium release into the sarcoplasm. This is called as calcium induced calcium release. Now this ECF calcium that goes in, it is responsible for this plateau phase. We saw that calcium comes in slowly, so it causes plateau phase. Plus that calcium also is involved in the contraction process. Yeah, plateau phase is the electrical event. Contraction also involves this ECF calcium which has come in, and then for the relaxation, for the diastole, this calcium has to be sent back from the sarcoplasm. Okay, its level will fall, diastole will happen. But imagine a drug like digitalis. It increases the sarcoplasmic calcium so much. You know, digitalis works by increasing the sarcoplasmic calcium. We have discussed it elsewhere. Now the calcium level has increased so much in the sarcoplasm that even if the calcium has gone out, so much calcium stays back in the sarcoplasm that it can trigger an extra action potential. It can trigger an extra action potential or depolarization, and it can trigger the extrasystole. So digitalis is responsible for such extrasystoles, and a run of extrasystoles is called when 3 consecutive cardiac cycles show the extrasystoles after depolarizations, and therefore the extrasystoles, and that is when medical intervention will be needed the run of extrasystoles, when 3 consecutive cardiac cycles will have such extrasystoles. Also remember, there can be extrasystoles in the ventricle, there can be extrasystoles in the atria. They are called as ventricular premature beats. Yeah, it's a premature beat, that's a correct term. Rather than calling it after depolarization, it's a premature depolarization and premature beat. And atrial premature beat. Ventricular premature beat is followed by a compensatory pause. You know why? Because when it occurs, this extrasystole occurs, heart is thrown into refractoriness, and during that refractoriness, the next normal synodal impulse comes. So it will find the ventricle into refractory period, so that beat will be lost. I mean, there will be no contraction. So compensatory pause. But atrial premature beats, atrial extrasystoles are not followed by compensatory pause. You know why? Because if such premature beat happens in the atria, then SA node gets adjusted to that beat. So next normal impulse it will send after a normal time only, not with its own clock. Means not with its own rate, but it will get adjusted to that premature or extra beat. So these are that is basically the second reason for arrhythmias, pathophysiologic basis for arrhythmias, the triggered activity. So just remember, after depolarizations got triggered, extrasystole got triggered, and resultant arrhythmias. The third pathophysiologic basis for arrhythmias was re-entry and circus movement. Since we are coming to the end of this chapter, so let me just finish that part. Remember, only three bases are there to cause arrhythmias: enhanced abnormal automaticity, triggered activity, like we said just now, extrasystoles triggered by digitalis or such drugs, and third one was re-entry and circus movement. Cardiac dilatation or such conditions can lead to arrhythmias. Why? Let's see. We are discussing the action potential in the Purkinje fiber. I have yet to finish that, but let's just quickly go through this part so that third pathophysiologic basis for arrhythmias is re-entry and circus movement. This can lead to arrhythmias. So let me quickly explain this. Suppose this is a piece of cardiac muscle fiber, or a region of the cardiac muscle, region of the heart, a piece of cardiac tissue. So Purkinje fiber brings the impulse over here, and then impulse starts traveling in this fiber. Now, as it travels and goes back to that original position, let's call it 12 o'clock position, what happens? This impulse finds this part still in the refractory period. So it cannot excite that part again, it cannot go in that circular path again. Impulse will simply die out. It cannot excite that region. That's the advantage of having a long refractory period. We will discuss this in 5 minutes. But then, now this is normal. But sometimes it can re-enter that same path and it will have that circus movements or circular movement. It will keep on circulating in the same path, and such multiple re-entrant circuits can develop, and that will result in arrhythmias. So when does that happen? When will it have that re-entry? First is if the conduction is slowed down. Length of the path is similar, okay, same length, but conduction velocity is dramatically slowed down. What will happen? By the time the impulse goes back, because it was traveling very, very slowly, so by the time it goes back to that 12 o'clock position, refractory period will be over. Then it can enter that path again, it can re-excite that path again. So slowed conduction velocity in a path is bad. It can cause re-entrant circuits. Second, as I mentioned, dilation of the heart, cardiac dilation. If the path length has increased, then what will happen? The impulse will take longer time to reach that original 12 o'clock point. By that time, refractory period will be over at this point. So it will re-enter again, and then it will have a circuitous path or circular path. And then the third reason is damage to the Purkinje system. So this can cause re-entrant arrhythmias, very slowed down conduction velocity or enlargement of the heart, dilatation of the heart, enlarged path. Okay, so we have seen three pathophysiologic bases of arrhythmias. We've seen the mechanisms and the causes that are responsible. Coming back to the discussion over here. Alright, we have already done the ionic basis of action potential in the fast response type, in the Purkinje fiber. So what is left now is only the advantages of the plateau phase. What is the benefit of plateau phase? The advantages of the plateau phase. Because of the plateau phase, there is a long action potential duration. You know, nerve action potential is hardly 1 millisecond. Purkinje fiber action potential duration is 200 to 300 milliseconds. Second, long recovery time means repolarization basically is prolonged. So recovery is taking longer time. And most important, long refractory period. Because the repolarization is taking long time, it's all the refractory period. And we have done this already. Refractory period is that period after every excitation during which another excitation is not possible. So, long refractory period, how it is beneficial? It means, therefore, heart cannot be excited at high frequencies, very high frequencies. Isn't it? Because only when the refractory period is over, heart can be excited again. So long refractory period means a long wait for the next excitation. So heart cannot be excited at high frequencies, and therefore heart muscle cannot be tetanized. Tetanus is not possible in the case of heart. What is tetanus? Sustained state of contraction and failure to relax that happens from high frequency stimulation of the muscle. It's possible in the case of skeletal muscle. If you remember, I gave the example when we are writing exam, toward the end, muscle goes into a sustained state of contraction. It fails to relax. We have to wait for some time. Why that happened was because high frequency stimulation to the muscles. So calcium could not be pumped out, very high frequency stimulation. That is possible in the case of skeletal muscle, but not possible in the case of heart muscle. Why? Because heart cannot be excited at high frequencies. And why is that? That is because heart has got a long refractory period. So that's the benefit of plateau, that the heart cannot go into sustained state of contraction. And heart cannot fatigue also. It gets enough time to recover. So it does not fatigue. Just refer to the section on tetanus once again and correlate. I have described it extensively, the muscle tetanus and how to calculate tetanizing frequency. So just refer to that once again. You will have a better conceptual understanding. So there we finish the first chapter on conducting system of the heart. Next we will take cardiac cycle and other topics.